ultrasound-guided regional anesthesia improved the efficacy of peripheral nerve blockade. And they had a very well previously defined search criteria and analysis. They identified 525 abstracts, of which 16 articles met their inclusion criteria with a total number of patients of over 1,200. Now, these randomized controlled trials were published between the years of 2004 and 2009, and I think this is something important to keep in mind because of something we're going to discuss in a couple minutes. Their primary outcome was successful surgical anesthesia. So they only selected randomized controlled trials that were reporting surgical anesthesia. So it was quite a strict criteria, and that meant that the block had to be sufficient for surgery without general anesthesia or without a supplemental block. They only compared ultrasound versus non-ultrasound method. They did not include any of the combined techniques, and they only include trials that referred to plexus blocks or peripheral nerve blocks. The results. So these are all the studies included, and as you can see, most of these studies already showed at least a trend towards a benefit with the use of ultrasound, and then they combined the meta-analysis of all these studies showed a significant increase in the rate of success when ultrasound was used. Now, you will likely say, well, 11%, is that, something really significant? Does it really make the blocks work better? Now, if you consider, I think there's a number of things we need to consider when we look at these numbers. The first thing we need to consider is that the baseline success rate was already pretty good. These authors that reported these studies are very well-known institutions doing regional anesthesia for many years, and their baseline success rate was already very good. So if you have a success rate at baseline of 85 or 90%, increasing 10% on top of that, it may be considered clinically important, clinically significant, because obviously, if you start with a 20% success rate, you can increase 100% your success rate from 20 to 40. But if you start at 85 or 90, a 10% relative increase in success rate is probably clinically significant. So the next two studies I'm going to talk about, and then we're going to do a reflection about the three of them. The next two studies have to do with the safety of regional anesthesia. So now I'm going to apologize because I already alluded to these two studies yesterday, so it may sound like a little bit of repetition to you, but I think there's a reason why I want to talk about them again. The first study is this prospective audit from this Australasian collaboration, 8 different centers, and they prospectively evaluated every single peripheral nerve block that they did in these 8 centers between the period of 2006 and 2008. And the main outcome they were interested in picking up was, again, the incidence of neurologic and other complications of peripheral nerve blockade. So the methods, they included every patient undergoing peripheral nerve block, both upper and lower limb. They used a specifically designed prospective online database. They used a standardized follow-up questionnaire that they called every single patient 7 to 10 days post-surgery. And they had a very standardized criteria of what kind of neurologic workup they would do for these patients if they had any new symptoms. So I thought their methodology was very sound. The results, they did roughly 7,000 patients that received over 8,000 peripheral nerve blocks. Because it wasn't that time between 2006 and 2008, it was a transition period where many of these centers were starting to incorporate ultrasound into their practices quite frequently. So about roughly 2/3 of these procedures were ultrasound guided, 1/3 was non-ultrasound guided, and they had an 83% of complete follow-up, which in an endeavor of this magnitude, I think is quite significant. Is quite a good completeness of their follow-up. So I think it makes their results believable. And as we mentioned yesterday, 30 patients were referred to neurology because of new symptoms, and only 3 of them were found to be block-related neuropathies. Why did I like this study? You know, you may think, well, this is something we kind of knew before, but to me, it really, first of all, I think it's a very sound study with good methodology, and it really reassured me because this was my, this was my impression beforehand. When I first started doing regional anesthesia, every time a surgeon called me to say, you know, this patient that you did this block on, you know, he has some numbness in the leg, so you better see him. So it really made me a little bit uneasy at the beginning, the first couple of calls that I got like these, you know, early in my career. But then, you know, as now I have a different take on it. I feel, and particularly this study, you know, it gives me something very sound and I feel very comfortable dealing with these patients. In fact, I feel thankful to the surgeons that call me because they give me an opportunity to get involved with these patients' workup from very early on. And I think it's very important to establish that kind of rapport with the patient to make them know that you do care about what's going on. And also gives me some very good sound data to say, you know, let's investigate it. You know, about 90% of the time there's another reason why this happened. It doesn't necessarily mean that it was the block, but we'll investigate you and we'll get to the bottom of the story. And most of the time, if this is work-related, these deficits are transient. So that's one of the reasons why I like this study. It really helped me to deal with these kind of issues. So again, the significance is very rigorous. It's a multi-center collaboration study. They had very clear standard follow-up. This is not meant for you to read, but to have an idea that they have a very clear algorithm that they followed. And again, it confirmed my clinical impression that, you know, about maybe 10% of these postoperative deficits are indeed block-related. So the other study that had to do with safety was a retrospective study from a single center. Again, I kind of alluded it a little bit yesterday. This retrospective review was once again done over a transition period for the first 3 years of experience in this single center using ultrasound-guided regional anesthesia from Pittsburgh. And their main outcome that we're interested in, once again, is the incidence of adverse outcomes. It's a retrospective review. They used a departmental quality assurance electronic database over this 3-year period. And they evaluated all single-dose peripheral nerve blocks. Now, even though this was a retrospective review, as part of their departmental quality assurance process, they do have a standardized 24-hour follow-up for every single patient that has had a peripheral nerve block. And again, as part of their standard procedures, if these patients report any kind of deficit, they're followed for longer. And if the deficit does not resolve within a week, they're referred to their physical medicine department for workup and management. So even though it's retrospective, I think their methodology for follow-up was quite sound. Well, the results showed that, again, this is retrospective data, but nonetheless, when it comes to seizures and local anesthetic toxicity, about 5 patients had this serious complication, and those 5 patients had a block done with nerve stimulator alone. And even though this was a smaller group, about half the size of the other, none of these patients had significant local anesthetic toxicity. And they did have 3 block-related neuropathies in the peripheral nerve stimulator group. And I think it's interesting that the 3 of them were popliteal, even though they were only probably about 1/5 of all the blocks. They report all kinds of upper blocks, upper limb blocks, lower limb blocks. And there was a lot of talk yesterday about the sciatic nerve in particular, how the sciatic nerve has a lot of stroma in it, a lot of fibroid tissues, and perhaps when we're using nerve stimulator, we really have to, do a few pokes before we actually find a response. So I'm not sure this is entirely hypothetical. I'm not sure why all of them were popliteal, but I suspect that as part of their quality assurance process, they probably, this particular fact must have called their attention, and they must have, tried to ask this question: what are we doing wrong that it seems to be, or particularly for this particular group of patients, that all our neuropathies essentially were in the popliteal blocks. So Did I move? Sorry. So the significance, again, this is early experience within one department, but I think it's very real-life type of results. And I think it's a very important quality assurance tool. And again, within, it's a very good example of how to, I think, use retrospective data well. So just a few words about the significance of these last 3 studies. And why, I think this is a timely thing to think about, because all these studies, large studies, meta-analysis, prospective reviews, have suggested that, as common sense would tell, we would think, sure, we can see all these structures, we can be so much more precise with our local anesthetic administration, we can get information about all the blood vessels that we want to avoid and so forth. Common sense would tell us that it should be like this, that we should have greater efficacy and greater safety with ultrasound-guided techniques. And the significance of this is that I think these studies were positive, despite what I think it was probably quite an equal experience at that time. And I think we need to remember the concept that was mentioned yesterday several times. When we are comparing regional anesthesia techniques, we're not only comparing the instruments, but also the musicians. And I can certainly speak for myself that, this is a totally hypothetical graph that I made over time. So, for example, for my own personal experience, I can say, since I started using ultrasound guidance, my first few blogs, for the first few months, I was extremely excited about it. But I'm sure they were not the greatest blogs I could do with ultrasound guidance. And I believe I have gotten much, much better at interpreting the images and at obtaining very good and very safe blogs. Now, there's always room for improvement, so I'm probably not quite at 100% yet. Now, likewise, I have to be very honest with you, and I have to say, I was using nerve stimulator before ultrasound. I thought I was pretty good at it, but I have to recognize that I use more and more ultrasound in my practice. I use less and less nerve stimulation, so I don't think I'm probably half as good today as I was, 10 years ago in doing nerve stimulator-only blocks. So why does this matter? Who cares about me? Well, so I think it's not just about me. It's about institutionally wise, when you take a group of anesthetists, if you're doing a comparative study early on in your experience, which a lot of these comparative studies were, you were probably comparing ultrasound at a disadvantage in terms of how well those musicians were using the instrument. However, the data is still positive. Having said that, if we wait too long and 3 years from now we try to replicate these studies, we're going to be putting the nerve stimulator at a disadvantage because we're not going to be as good at it anymore. So, I think we're coming to a point when, well, we've done all these studies, what they show makes common sense, and we're probably not going to see many more of these comparative studies, because I think if we do, we are going to be putting the control certainly at a disadvantage, and no fault of the nerve stimulator at that point. That's my own take on the issue anyway. The last study I want to refer to is slightly different. It has to do with neuroaxial techniques. Now you may say, well, it doesn't look very good to say that it's a very significant publication when it comes from your own group, but I certainly don't take any credit on this. It's the work of Dr. Chin, one of my colleagues, and I think it's a very nice study. It's a randomized controlled trial looking at the impact of neuroaxial ultrasound on the performance of spinal anesthesia. Why I think this study is different and important, because Dr. Chin included in this study all the patients that are traditionally excluded from any other study. So he thought, well, what I really care, we can all do spinal anesthesia, or so we think. But where we really struggle, where we really have problems, is the patients that are big and I cannot palpate anything, the patients that have underlying scoliosis or other pathology, and the patients who have had surgery. Those are the patients that we tend to struggle with, and those are the patients that tend to benefit the most sometimes from receiving a spinal anesthesia. These patients, because they very often have obstructive sleep apnea, difficult airways, so these are the ones that we really want to do a spinal anesthetic, and these are the ones ones that we often struggle the most and end up at higher risk of complications as well. So it's a randomized trial. They randomized the patients to pre-procedure ultrasound versus landmark technique. They used a blinded observer to document all the outcomes, and the primary outcome was success at first attempt. The way they did the ultrasound has been thoroughly discussed in the last couple of days, and what the results showed, I think it's highly significant. You know, it showed that if you do an ultrasound scanning prior to spinal anesthesia for orthopedic surgery in these very difficult patients, you're twice as likely to be successful on your first attempt than if you don't. I think this is a tremendous help clinically, and I think it's a very well done study, and that's why I think it's quite significant. And as I said, I think this is exactly the group of patients that benefit the most from these techniques. They are the ones that most need it, and they are the ones that are at greatest risk of complications, both from a regional technique or from a general technique if we can't do the regional. So in summary, we have looked at one meta-analysis looking at the efficacy of surgical anesthesia for peripheral nerve blocks using ultrasound. We've looked at 2 studies looking at the issue of safety and 1 randomized controlled trial looking at ultrasound for difficult spinals. Thank you for your attention.